day one file of the October recalls. Okay, so we will try to finish as much as we can. Like in October, there were not too much recalls like November, but November recalls were like so much, right? Everyone has remember, right? Because we had to do 3 days for day one file, right? That much long. And we got so much doctors participated in November exam. That's why we got so much recalls. Okay. Okay. So a 35-year-old man present with 1.5 painless scrotal swelling. Notice incidentally, on examination, the testis and spermatic cords are palpated normally and there are no urinary symptoms. The swelling is firm and non-tender. What is the most appropriate definitive management? So, transscrotal surgery, aspiration by needle, reassurance and review after 3 months, transinguinal surgery. So, what do you think? What do you think about this question? Type your answers in the chat, then we will discuss. What do you think? Type your answers in the chat. What about other doctors? What about other doctors? They are asking about the definitive management, right? What do you think about the diagnosis? What do you think about this one? What do you think? So, what are the painless scrotal swelling? The painless one. Give me some example. Painless scrotal swellings. We have two types, right? Scrotal swelling. Okay. Let's check about the scrotal cell. We have discussed this one, but it's still okay. Okay, when we talk about the scrotal swelling, there are two types: painful scrotal swelling and painless scrotal swelling. In our question, they have mentioned about non-painful scrotal swelling, right? So, what are the example? Those are hydrocele, varicocele, idiopathic scrotal edema, or it could be a tumor, testicular tumor, or leukemia cases, usually testicular tumor. So, and in our case, and how this hydrocele present. I'm just like quickly discussing about these painless scrotal swelling. How hydrocele present? There's no fever. Uh, when we palpate this hydrocele, we can feel soft, non-tender, fluctuant swelling right in here. And the swelling pattern is scrotal. And we all know transluminable test is positive in here. We can see it as a bright light, right? I'll show. Okay, this is how we can see. Okay, that's why we call transluminable. Okay, then how varicocele present? We have discussed a question in November recall sessions as well, varicocele one, right? So varicocele is there's no fever, and varicocele we can see it as a bag of worm, right? And it's occasionally tender, and here predominantly in left-sided. Okay, remember this. And what are the other features of the varicocele? What is happening when patient is standing? Varicocele in varicocele. I have explained this in November recall class as well. Okay, you should remember how. Hurry up, doctors. You should remember. What are the other features of varicocele? Okay. What others? I'm just asking because varicocele question is in November as well. It can be in February as well. Okay, that's why I'm asking. And in the varicocele, yeah, usually when this swelling is prominent on standing and reduced with lying down, right? Remember that part. Uh, if you can go and check August exam question, the exact image question, that question, they have mentioned this part as well. Okay, that's why I'm again revising it. Okay, that's it. Um, Usually, hydrocele is a very important part. Then idiopathic scrotal edema. There's no fever, non-tender, may have low-grade discomfort. Here can extend to the across midline and into perineum, groin, penis. Okay, and the discoloration can be seen here, bland, purplish. Okay, then what about tumors? Fever possible, but the palpation can be hard, non-tender, may be painful if rapidly growing, otherwise not painful. Swelling pattern is unilateral or it could be bilateral as well. And there can be a reactive hydrocele as well, possible case. Okay, yeah. In our case, what they have mentioned in our case, in they have mentioned what this is incidental noticing, and it's a 1.5 painless scrotal swelling, and there's no UTI symptoms, so we can exclude UTIs. And they have mentioned the firm and non-tender one, right? Firm, non-tender. So they are asking most appropriate definition. What do you think about this one? This is not hydrocele. This is not varicocele. This is not idiopathic scrotal cell. Then what we can think about in here? Like what is the diagnosis? It can be testicular cancer, right? Okay, I'm here. The palpation. Okay, so it can be a testicular tumor, right? Yeah. Yes, okay. We have to go like that. Okay, you have to answer. But in November, recall sessions, you all active, right? Why now? I bored about the October recalls. October recalls are kind of weird, not like November, but still okay, right? Mm. So in that case, what we can do in here? They are asking most appropriate definitive management. Okay. Before that, we will do one question. Okay. And we will come back to our main question as usual. Okay. First, we will do this question from the eMedici. A 32-year-old man present to the general practice clinic with a 3-week history of painless mass in right testicle that he noticed while showering. He has no significant medical history and take no regular medications. And he has a 4-pack-year smoking history and drink 2 standard drinks of alcohol per day. On examination, he appears well, vital signs normal, and the right testicle contain firm, non-tender 5 centimeter mass. The left testicle and epididymis epididymis are normal. There is no inguinal lymphadenopathy. Scrotal ultrasound shows the homogeneous and hypoechoic mass with well-defined margin. Which one of the following is most appropriate investigation to establish the definitive diagnosis? So, what do you think? So, what do you think? Type your answers in the chat. Type your answers in the chat. We will discuss then it. Okay. What do you think about this question? So usually, like you're asking about hard and firm. So, what is the difference between hard and firm? It's kind of similar. There's a small difference, but kind of similar meaning. Hard mean there's a resistance to the pressure. Okay, but firm mean it's kind of solid, right? Solid thing, and it has some shape kind of thing. Okay, but usually the words are similar. Okay, think like that. So, what do you think? Okay, they're asking, okay, most appropriate investigation to establish a definitive diagnosis. So you all think it as one, and some other doctors go with four and E as a. Okay. Let's check the question. Okay, that's why I have added this question. I want to explain this part clearly. I know you have no idea about this part. Okay, so here this patient present with clinical and ultrasound finding highly suspicious for the testicular cancer. So they have already done ultrasound here. A scrotal ultrasound shows the homogeneous and hypoechoic mass. So why we should do the ultrasound again? They have already done it, okay? Then the presence of painless testicular mass in young men require urgent investigation to exclude malignancy, while tumor markers are imaging studies are important for staging definitive diagnosis and require histopathological examination of the entire testicle. Uh, Next question focus on how to make a definitive diagnosis in situations such as this where there are strong clinical suspicions of diagnosis testicular cancer. So staging investigation including tumor markers, then CT of the chest, abdomen and pelvis will be performed before osteoporosis considered. This will help to guideline the managed decision. So, radical orchiectomy through an inguinal approach is a gold standard for both diagnosis and initial treatment of suspected testicular cancer. This approach avoids the disruption of scrotal lymphatic, which could lead to the altered pattern of metastatic spread. The inguinal approach allows the high ligation of the spermatic cord and at the internal inguinal ring. So you get it. You get the question right. You got it right. Yeah, they are asking what is the most appropriate. We have to diagnose it, right? Like we don't know, like without histopathological proof, we don't know it's a cancer or not, right? In that case, to establish the if it is cancer, we have to remove it, right? In that case, we have to do the radical orchiectomy. Okay, this is the diagnostic and therapeutic intervention. But usually we are starting with the ultrasound, right? Ultrasound, then we have to do the CT of the pelvis, abdomen, and chest, and we have to check the what? We have to check the tumor markers as well. We have to know the stage of the cancer, right? Is it spread or not, like that? But they're asking what is in appropriate investigation to establish a definitive diagnosis. So, what is a definitive here they have mentioned radical orchiotectomy is the both diagnostic and initial treatment suspect testicular cancer. Okay, you got the point right here. And some other doctors mention it has the serum alpha fetoprotein. Okay, let's read that one as well. Serum alpha fetoprotein is an important tumor marker that aids in diagnosis and monitoring of the non-seminomatous germ cell tumor. However, tumor markers alone cannot provide the definitive diagnosis and may be normal in some testicular cancers. Okay, so radical orchiectomy via an inguinal approach is required to provide definitive histological diagnosis of the testicular cancer. Scrotal procedure including biopsy and fine needle aspiration are contraindicated as they Risk of lymphatic spread. Tumor markers and imaging help with the staging but cannot provide the definitive diagnosis of the testicular cancer. You got the point, right? Okay, one more question, then done for the testicular cancer. 30, these have different concepts. That's why I have added, okay? You know from the numerical as well. So then you will easily remember. Otherwise, it's very hard to remember the theory parts. Like with a question, it's easy to remember and I understand the theory behind it, right? Okay. A 30-year-old man, okay, 30-year-old man present to the GP clinic with four-week history of scrotal swelling. He noticed swelling after game of soccer when he thought he might have been injured in that area after rough tackle. The left side of the scrotum and contents are normal, and on the right side there is a firm 6 centimeter diameter non-tender swelling which does not transluminate, so we can exclude hydroxide. Ultrasound confirmed the homogeneous intra-testicular mass, low echogenicity compared to the normal testicular tissue. The patient has a CT of the chest, abdomen, pelvis, which shows no evidence of lymph node involvement or distant metastasis. There's no elevation of alpha fetoprotein or HCG. Which one of the following is most appropriate plan of management? Active surveillance, radical orchiectomy, chemotherapy, retroperitoneal lymph node dissection, radiation therapy. So, what do you think? Type your answers in the chat. Type your answers in the chat. Doctors, please type your answers in the chat. Everyone has to type in the chat. Mm-hmm. What about other doctors? We just discussed, right? Okay. That's why I'm telling you to take the concept, not the question. Take the concepts. Okay, so some doctors going is still active surveillance, other doctors going is radical orchiectomy. Okay, let's check. It's the radical orchiectomy. We just discussed, right? Okay, so the most important diagnosis to consider is testicular cancer. Initial assessment involved scrotal ultrasound followed by CT imaging. So, like when I'm discussing these points, after giving after I give this PDF, you can just write down in somewhere else. Okay, like example, this is the diagnostic algorithm, right? We can do the ultrasound, then CT imaging of the chest, abdomen, pelvis, then tumor markers. Like why these we are doing? Like you have to like take the concept behind these small parts. Okay. In these tumors, confident to the testicle, there are normal level of serum tumor markers and CT scan is normal. It is most probable that this patient has a stage 1 seminoma. Radical orchiectomy alone will cure most patients with stage 1 seminoma and can confirm the diagnosis of histology. Do you remember this is a radical orchiectomy is a diagnostic and this is a therapeutic one, right? Please remember if you need to like definitely diagnose it, you have to like we have to diagnose and we need to decide the definite treatment, then we have to do the radical orchiectomy, right? Please remember. We are doing CT and tumor markers to exclude the metastasis like that, okay? Then why not active surveillance is appropriate? Then you should know when we use active surveillance, when we use radical orchiectomy. Okay, let's check. Is appropriate for patients who have been treated with osteoporosis as 10 to 20% of patients experience disease relapses. This patient has not yet had osteoporosis, so this answer is incorrect because of patients still need the definitive management, right? Usually if there's a cancer and if we can remove it and patient is surgically eligible, so in that case we have to remove it, right? In this patient it's not metastasis, so like we can just remove it, right? Okay, so let's check why not chemotherapy. Chemotherapy is available as an adjunct therapy to orchiectomy for patients who are not able to undergo active surveillance or desire reduce risk of relapses but is not an appropriate definitive treatment and therefore incorrect. So yeah, we are not doing retroperitoneal lymph node dissection for this patient because there's no metastasis here. May be appropriate for stage 1 non-seminoma to reduce the risk of relapse, but this has not yet been diagnosed. Thus, this answer is incorrect. Radiation therapy, appropriate alternative to chemotherapy. Okay, but this is not the definitive one here. A scrotal swelling will often go unnoticed until some apparent trauma bring the problem to the patient's attention. So now let's go to our question. And then what do you think about this question? Again, I'm asking. A patient is 35, is a young patient, 1.5 painless scrotal swelling, noticed incidentally, and testis and spermatic coda palpated normally, and there are no urinary symptoms. The swelling is firm and non-tender. Then, what is the most appropriate definitive management? What do you think? Don't mind the recallers language, okay? They have mentioned some like small one or two word differently, but still you can like get the idea, right? You did like proper two questions, like exam oriented questions. So in that case, what do you think? Yeah, it is. They have not directly mentioned about the this radical osteotomy, okay? But in this case, it's still we can think about transinguinal surgery because they have here mentioned here through an inguinal radical osteotomy through an inguinal approach is a gold standard, right? So here I think they have mean here the radical osteotomy, but if the fifth answer is radical osteotomy, so you have to go with that because that is the definitive treatment, right? For the testicular. You all agreed or not? If you have any question, just tell me. Or you are not agreeing, you can just tell me. I have had another question. Okay. Okay. We'll do this question as well, okay? Because I know there's no proper note for this part, right? Do you have any note for this testicular cancer, like a proper one, like related from the like you proper Australian guideline? I don't think so. If you have, it's good, but I don't think. So you have to make your own notes from these eMedici question. Even when I was preparing, when I can't find any note like from the guideline, I used to do the related eMedici question. Then I gather information and make my own note. Okay, like that I did. Yeah. Otherwise, well, 23-year-old man presented 4-week history of painless swelling in the right side of his scrotum. He has no other symptoms on examination, only abnormal finding is enlarged non-tender right testis. An ultrasound shows the 5 centimeter heterogeneous hyperquick mass with some calcification. The normal testicular tissue has been replaced. Tumor marker studies are all with normal range and X-ray is normal. Which one of the following most appropriate next step? Needle biopsy, CT abdomen and pelvis, MRI abdomen, pelvis and scrotum, transscrotal exploration, inguinal osteotectum. They are asking what is most appropriate next step. Next step, what do you think? I'm not asking definitive management or anything, just okay, you are going with okay, let's check. Here, here, remember I mentioned the algorithm, right? First, we had to do the ultrasound, but in this case, patient is done with the X-ray. Then we should know, right, if this one is metastasis or not, right? In that case, we have to do the CT of the chest, pelvis, and abdomen. Okay, let's read this one. Even without any further investigation, this young man almost certainly has a testicular cancer. The ultrasound finding here they have did the ultrasound here hypoechoic mass. Okay, so I missed that part. So ultrasound also done. Okay, non-seminomatous tumor. 1/3 of these patients will have tumor markers within the normal range. One of the diagnoses of the testicular cancer suspect the tumor must be stage and CT of the abdomen and pelvis should be the next investigation. So imaging should almost be considered an extension of the physical examination. Okay. Yeah. You all get the points, right? You have to answer what they're asking. Yeah, they're asking just most appropriate next step, right? In this question also, you see, right? They ask it most appropriate plan of management, but they have already done the CT of the chest and they have checked the tumor markers, right? Okay, now you can understand the points, right? These are the different types of question they can ask in the exam. Understood or not? Good, right? All good, right? Okay, now you know the weak points of yours, right? For the testicular cancers. Please make your own notes, okay? Please make one. Okay. So I have mentioned about the testicular cancer and clinical features. Here, the painless testicular scrotal mass, most common. It's in the chat. But yeah, first of all, you have to eat well, right? You need energy. So, okay, then testes may feel normal in early stage, like in our case, right? Now, testis and spermatic cord feel normal, right? In our case, heaviness or dull ache in scrotum, rarely acute pain due to hemorrhage, but it is not the like typical presentation. Advanced disease, it can be back pain, cough, weight loss when it's metastasis. Okay, so here testicular examination, scrotal ultrasound, tumor markers. Okay, then further management are staged in with CT of the chest, abdomen, and pelvis. Okay, and here definitive management, radical inguinal lociolectomy, or we call it transinguinal approach. I have added this part because in our question they have mentioned this part, transinguinal approach. Okay, that's a diagnostic and therapeutic. Okay, you all got the points right. What happened to Dr. Bhagya? I didn't see Dr. Bhagya yesterday as well. She's actively participating in every questions. So I didn't see her. Okay. So the next question is a 48-year-old female asymptomatic with family history of osteoporosis in sister, breast cancer at 65. Okay, 65 of her mother, and 68-year colorectal cancer in paternal grandfather. So ask about screening, yearly DEXA, 5-yearly colonoscopy, 2-yearly FOBT, 3-yearly mammogram. So what do you think about this question? So, what do you think about the answer? First, you have to answer, then we will together discuss the question. Please hurry up, doctors. Tomorrow is the new year, right? We can't delay anything, right? So, hurry up, hurry up. You have to answer quickly. Okay. Okay. Before that, we will discuss one by one how we should screen colorectal cancer, breast cancer, and then let's check about the osteoporosis as well. That screening and the treatment chart. Okay. But actually, there's no proper screening for osteoporosis. Actually, is there anything trial mammogram? Is there anywhere mention about trial mammogram? I'm just asking. Is there any trial mammogram for the this one? Yeah, it's too early, right? So why everyone say like it has a three yearly? They haven't mentioned anything about three yearly, right? We have annually and 2 yearly mammogram only in the screening protocol. We can't change the screening protocol, right? Okay, it's fine. Let's discuss first the colorectal cancer. So, when we think about the colorectal cancer screening, I have explained this in November class as well, but it's fine. I'll explain again because we have a new doctor. So, we have to categorize patients into three types: average risk, moderate risk, and high risk. Okay. So, this is from the Red Book as well. Okay. I made this table. So, average risk mean in here no family history of colorectal cancer or one first degree relative diagnosed at age of 60 or older. Remember the magical word for colorectal cancer. The magical age is 60 here. Okay. And uh, in previous, in the old guideline, it was 54. But don't confuse these two. The new guideline has mentioned the new protocol as a 60 years. Okay. So here, relative diagnosis at age 60, first year first degree relative diagnosis at age 60 years or older. In this case, risk is near average. Then what is moderate risk? Moderate risk means one first degree relative diagnosed before 60 or one first degree relative plus one or more second degree relatives in any age, or two first degree relatives diagnosed at any age. In this case, the risk at least two times higher than average. Okay, so you should know this criteria. Then high risk, two first degree relatives and one second degree relatives with at least one diagnosed before 50 years, or two first degree relatives and two or more second degree relatives, or three or more first degree relatives diagnosed at any age. Okay, you have to remember three criteria. Here also three criteria. Here also two criteria. In this case, risk at least four times higher than average. So in our question, so what is the average risk of this female patient? Her paternal grandfather. Paternal grandfather mean which degree? First degree or second degree? First degree or second degree? You have to answer. Yeah, it's a second degree. So, in our patient, in which category? Diagnosed at 68. Which category? Is it average, moderate, or high risk? It's average category, right? Okay, so we conclude one part, the colorectal part in this scenario, that is average risk of this patient because it's more than 60. And then here, how we should screen these patients. Asymptomatic adults age 45 to 74 years and screening with FOBT every 2 years. So we have that answer in the in our options, right? So keep in mind. So for the average risk patient, we can do FOBT every 2 years. And remember, this colonoscopy is not routinely recommended in average risk patients. Okay, please remember. Then the second one, a moderate risk patient. In moderate, it is in the chat. Yeah, in moderate risk patient, colonoscopy is recommended every 5 yearly. And what is the starting age? Starting age 10 years younger than the earliest colorectal cancer diagnosis in first degree relative or age 50 year. Okay. So as example like that, if a man presenting with the history of colorectal cancer at his father, colorectal cancer, history of colorectal cancer of his father at age of 55. So, in that case, when this patient's age is 30 and father's diagnosed at 55, and in this case, when we should start the screening of this patient. This patient is moderate category. So when we should start? Father diagnosed at 55. That means when we should start? Yeah, we should start screening this patient at 45. That's mean here the earliest first degree relatives age. That means the father's age. So the father's diagnosed at 55. We have to reduce 10 years from that. That means 45 years we have to start the screening, right? Yeah, that's how we should remember it. I give an example for that. Okay. Yeah. Then, age of 50 years, whatever is earlier. Okay. Please remember this one, whichever is earlier. And we have to continue until age of 74. Then the not severe, sorry, the high risk patients, they also colonoscopy is recommended at every 5 years, and the starting age is 10 years younger than the earliest first degree diagnosis age or age 40. Here age 50, here age 40. So here whichever is earlier, and we have to continue till 74 years. Okay. And there's one more thing you should know. We have to refer the genetic for familial cancer service if the patient is like a risk for Lynch syndrome. Lynch syndrome means patient is having history with other family members with like pancreatic cancer, endometrial cancer, ovarian cancer, like that. In those cases, we have to refer this patient for the genetic risk assessment. Okay. Uh, Today it's not the topic, but we have discussed this part in the November. Uh, that I have added the question because we got like similar question for the genetic assessment. Okay, like that. Then let's discuss about the uh, breast cancer. Okay, breast cancer also we are categorizing. Yeah, breast cancer also average, moderate, and high risk. So, who are the average risk? Who are the moderate risk? Who are the higher risk? Who can tell me? No, doctor. F4BT is F4BT only for average risk patient. Okay, here don't confuse with the all guideline because all guideline they have mentioned colonoscopy and FOBT in the moderate cases as well. Okay, that's what I'm telling here. FOBT we use only in average cases. In here, moderate and high risk cases we are using colonoscopy. Okay, not FOBT. Please don't confuse. Okay. Yeah. Okay. So here who are the average risk patients, not the patients, average risk women for the breast cancer? Who can tell me? Who can tell me? Okay, I'll tell. Here they have mentioned uh, no confirmed family history. That's one point. Oh, next one. One first degree relative diagnosed with breast cancer at age of 50 or more than 50. For the breast cancer, the magical age is 50. And for the colorectal cancer, it's 60. Please remember these ages, okay? It's 50. Or one second degree relative diagnosed with breast cancer at any age, okay? Remember. Then two second degree relatives on the same side of the family diagnosed with breast cancer at age of equal or more than 50 years, or two first or second degree relatives diagnosed with breast cancer at age equal or more than 50 years but different size. Okay. Yeah. Then these are the moderate average risk. So, what are the moderate risk? One degree relative diagnosed with breast cancer at age less than 50 years. This is not hard. You can just summarize it. Okay. I know this feel like it's hard, but it's not. Okay. And one degree relative diagnosed with breast cancer at age less than 50 years. Here more than or equal to 50. Here less than 50 and without any additional features of the potential high risk group. We will explain it. Then, two first degree relatives on the same side of the family diagnosed with breast cancer. Then, the next category is two second degree relatives on the same side of the family. Okay. Diagnosed with breast cancer at least one at age less than 50 years. So these are the moderate risk group. Okay. So who are the high risk people? Two first or second degree relatives on one side of the family diagnosed with breast or ovarian cancer plus here plus one or more of the following features of the same side of the family. Additional relatives with breast or ovarian cancer, then breast cancer diagnosed before age 40, bilateral breast cancer, breast and ovarian cancer in the same woman, uh, Ashkenazi Jewish ancestry and breast cancer in male relative. Please remember this criteria, okay? Then, one first or second degree relative diagnosed with breast cancer at age less than 45 years, plus another first or second degree relative of the same side of the family with sarcoma. Okay, we all know sarcoma, bone over soft tissue cancer at age less than 45, then member of a family in which the presence of the high risk breast cancer gene mutations like BRCA1, BRCA2 has been established. I know this kind of hard, but usually they are not asking like everything, like each point. You just keep a summary like a generalized a rough idea from each group, like how to differentiate from average, moderate, and high risk group. Okay, you don't have to remember like each point, this and that. I know it's very hard, but you have to differentiate these three, right? In that case, you have to remember at least few points. Okay. If you are familiar with recalls, like usually they are when they are asking, right? Like from which category, from like what they are asking, like that. Okay, please do the emergency questions as well. So the recommendation here, women at average risk or slightly higher than average risk breast cancer should participate in mammographic screening from age 50 to 74. So starting from 50 every 2 yearly for average risk. Okay. Then screening by mammography is not recommended in women aged more than 75. Okay. Remember? Then, okay. The next one is undertake mammography screen from 40 to 74 women at moderately increased risk at least every 2 years. Here, the at least every 2 years. Here, every 2 years. Okay. Then, 1 minute. I have to add small part. Give me 1 minute. I haven't add that small part from the this one. Okay. For the high risk one. Yeah, for usually for the high risk one, it's better to do the annual one, annual mammogram screening as that. Okay, for now, just remember I will add that therapeutic, not the therapeutic guideline, the red book part. Okay, yeah. For the average risk, every 2 yearly. For the moderate risk, like at least every 2 yearly. For the high risk, it's actually better to do in annual breast imaging. Okay, found it. You all have the red book, right? Okay. And, here, here they have mentioned the specific population potentially high risk or carrying a mutation. In that case, regular clinical breast examination and annual breast imaging with a mammography. Okay. Or MRI or ultrasound. Just remember it as a annually, okay? So in our case, what do you think? What do you think about breast cancer history? Patient is 48 and her mother has a breast cancer at 65. So which category is this? Which category? Which category? Please answers, doctor. Yeah, it's average risk. So in that case, we have to do the 2 yearly mammography, but they haven't given anything about 2 yearly, just 3 yearly. There's no protocol for 3 yearly. So please don't mix it up because most of the doctors have answered it as D, right? So please don't confuse. These are pure marks, okay? You just need to know the screening protocol, then you can easily understand. Okay, let's be discuss about the osteoporosis. Okay, here actually there's no proper protocol for the like screening protocol for osteoporosis, but we can go in with some this chart. Okay, there's frax calculation calculated. Okay, let's be discuss. Our patient doesn't have any fractures or anything. Oh, so risk factors with no fractures, like these some non-modifiable fractures like age of more than or equal to 70, parent with hip fracture, falls, poor balance. What is in 1 minute? What is in our question? Yeah, osteoporosis in her sister. Okay, just only in sister. So risk factors, no fractures. In that case, patients having falls, poor balance, low physical activities like low body weight, low muscle mass. In these cases, we can use Frax calculator to check the risk. Okay, that's only. If this risk is equal or more than 10%, then we can refer this patient for the DEXA scan. Okay. Or if this patient is present with the early menopause, hypogonadism, celiac disease, rheumatic arthritis, primary hyperparathyroidism, these are, you can read it later. We can direct this patient to the DEXA of the spine and proximal femur. Or if the patient is taking glucocorticosteroid more than 4 months, and this dose should be more than 7.5 milligrams per day. Okay, in these patients also more prone to have osteoporosis. In that case, so an excessive thyroid hormone replacement, androgen deprivation therapy, aromatase inhibitors. In that case, also we can think about DEXA. Otherwise, there's a no protocol for screening. Okay, please remember that. But in our question, we have a good protocol, right? The proper one for the colorectal cancer. In that case, we can go with that, right? Here. So here 2 yearly FOBT, right? So yeah, we can go with that. Okay. So we will discuss osteoporosis like properly tomorrow because in day one we just got like five questions from osteoporosis diagnosis and management. That's it. Okay, we didn't get a proper question or anything. Just that because it's a recaller mentioned that. Okay, so in that case, the better questions came in day 2, 3 because this osteoporosis. So we will discuss it in tomorrow. Okay. Yeah. I'll show how the recaller send it. So you all are clear with breast screening and colorectal cancer screening, right? Yes or no? Yes, right? Okay. Next